pain manages a pitch invasion. So if we see what is the definition of the pitch invasion as per Wikipedia, a pitch invasion is also known as field invasion, field intrusion, rush into the field, storming the field. It occurs when an individual or a crowd of the people watching a sporting event run onto the playing area to celebrate or to protest. Very, very important thing. So let's correlate with this pitch invasion with the students' healthcare as per my thinking. So it is a stadium. What is the stadium? Where the game is going is the art. What is the pitch? The pitch is the hospitals. Okay. What is the game going on in the ground? That is the treatment to the chronic pain suffering patients. Okay, specifically chronic pain, not the acute pain. Who are the players? The players are the treating doctors like physicians, orthopedicians, neurosurgeons, physiotherapists, anybody. And who are the people in the gallery? The patients' relatives, other specialty doctors. So during this game, last 20, 30 years, some doctors, doctors, they're coming out from the gallery and coming into the pitch as a pitch invaders. Okay. So they are called pitch invaders by these treating doctors. But my question is now, are the pain managers coming into the field to celebrate or protest the game? So they are neither coming for the celebration nor coming for the protest. Because there was a demand. There was a demand in the pitch to support the game, to make the game more enjoyable. Okay, because it is not the fault of the players, it is not the drawback of the players why the game is not properly supported, not enjoyable. So it is the limitation of the subject where chronic pain patients are not getting relief. So that is from that point, this pain management specialty developed. It has a history. It's not that I have developed. So let's go to the history first. So how the pain specialty developed. So if you see that John Joseph Bonica, okay, when he was 27 years old in 1944, he became the chief anesthesiologist at the Madigan Army Medical Center. And he became captain. In his treatment, he has treated lots of veterans in World War II. And then he dedicated himself to understand the elevated chronic pain. In that way, he started his world first multidisciplinary pain management center in 1960. So he is our father of pain management. And just for your information, the picture what you are watching, this is my tribute to John Bonica with my pencil sketch. Okay, so different important chronic pain conditions which can be managed by interventional pain physicians. I will mention some specific things, specific incidences. So we can say this is a sophisticated or targeted palliative care. Okay, blocking the pain transmissions. Many times we will see we may not control the disease, we may not control the change of the pathology, but we can reduce the pain transmission. That gives tremendous relief to the patients, because many times patients are suffering with pain, with lots of treatments. I will come to this point. And everywhere, interventions has to be done under vision. There is no point of doing interventions blind. Today, everything is available in OT. 20 years back, the CM also was not available in the OT, we have seen. So now USG guided, USG will become like it will replace your stethoscope. So everybody has a right to understand, right to learn USG. It is not a tool of sonography. Then why we are using the CM? So it is not, sonography has to be learned by every doctor for bedside diagnosis, for interventions. So the complications will be very, very less, and within minimal time, you can do the intervention. So let's see some interventions where pain management, lots of interventions are there, where pain managements are very, very helpful to help the game. Say first importance is a tailbone pain, coccydynia. Many patients are suffering. Tomorrow I have a scientific topic on this, this topic, coccydynia, tailbone pain. In those cases, many times patients are not getting relief by regular treatment. So then what to do? So if you see there the last, the sympathetic ganglion, that is, we can block that. So this can be done, all the treatments can be done in 2-stage. Phase diagnostic, then you can go for long-term relief by radiofrequency ablations. So in front of the sacrococcygeal joint, we are blocking this nerve, tremendous immediate relief patient gets, and after that, if patient is coming back again, because the effect is gone, then we can burn this nerve because this is a sensory nerve, it will not affect any kind of motor activity. The patient will be very, very helpful. I will discuss tomorrow about the detail of the technique. So in that way, under fluoroscopy guidance, we can block this nerve and we can give a very good relief to the patients suffering with coccydynia. Let's come into the facet arthropathy. If you see the facet joint, knee joint, they're almost same. The synovial joint. For knee, what you can do, maximum you can replace. But for facet, you can't help. In those cases, if many times patients are suffering, patients are telling doctor, first relieve my pain, then I will go for exercise. So we can block the pain transmission without changing the disease. Okay. Same way we are giving the medial branch block. Now coming for this sacroiliac pain. In the same way, you cannot replace it. We can block this joint by giving radiofrequency as well as for the steroid injections. Even nowadays, going for the neuromodulations. Discogenic pain. Many patients are suffering with disc degeneration, annular tear. In those cases, PRP therapy or stem cell therapies are giving very good results. Post-laminectomy syndrome. So many patients are suffering after laminectomy or after spine surgeries. In those cases, if anything is not working, we can go for neuromodulations in those patients. Other important cases, besides orthopedics, we can go for. If you see, some patients are getting severe headache after CSF leak without any reason. The CT myelography, if we can find out where is the leak, we can put the epidural blood patch tremendously. Immediately, patient will get the relief. Okay, it is happening. I have published papers. So another thing, ischemic pain, the peripheral vascular disease. So many times, pain relief, those who are suffering pain, they only know what is pain. Nobody knows those who are suffering, those who are not suffering. In those cases, pain relief, even if you are not changing the disease, you can relieve the pain, patient lifestyle will be totally changed. Cancer pain, another thing, even after major surgery, chemotherapy, everything done, still patient is getting pain. So we can block the pain by blocking this major nerves that is working the cancer. Here is the transaortic celiac plexus. I don't know whether the video will work here or not. So we can see how we are blocking the celiac plexus, piercing through the aorta and going in front of the aorta around the celiac plexus. We are blocking through the alcohol. It gives tremendous relief to the patients to come back to the life. The most important, trigeminal neuralgia, neuropathic pain. Many patients are suffering. There is no reason why they are getting pain. So we can block the pain transmission. That's changed the life. So in conclusion, I will say pain managers are not the speech invaders. Neither the pain management is a speech invasion. Because it is an important subspecialty of the anesthesiology for chronic pain management. After managing acute pain in OT, casualty, ward, anesthesiologists are capable of managing chronic pain through different interventional techniques. Because pain is multifactorial, which needs lifestyle changes, physiotherapy, operative management, psychotherapy. On top of that, interventional pain is the most important thing which completes the circle. So nowadays, I have started cadaveric workshop in MGM where I am taking monthly fluoroscopy guided workshops for pain intervention as well as bi-monthly the ultrasound guided workshops where everybody is welcome there, because many times from remote places orthopedicians, neurosurgeons are coming to learn, because many anesthetists are not learning these techniques because they are so busy with anesthesia. So then if you are also learning this and helping your patients, ultimate target to relieve the patient. So pain is the toughest enemy of human being. Unless you develop yourself a stronger soldier, you won't be able to fight with the pain. It affects psychology, it affects autonomic nervous system. That's why it is affecting each and every system and affecting the patient's whole life. That's why pain should be taken as a fifth vital sign. And now I'm requesting the surgeons give more time and value to the post-op pain management, because many times acute pain turns into chronic pain. And we know now pain is inevitable, but suffering is optional.